Hi, everyone. Welcome to our August ICARE case conference. So I wanted to get started with one of my cases right before we get into our guest expert talk. So thematically aligned with the guest expert talk. So the patient history is, this is a 34-year-old female recently diagnosed with stage 2B ER/PR HER2 positive breast cancer. The BRCA2 mutation was identified in 2019 based on the family history. She is getting neoadjuvant chemo, and patient at this point is deciding on surgery type. Now, here's a family history. She is BRCA2 positive. And my recollection is it's coming from dad's side of the family. So I ran her CAN risk, and what you see here is pretty high contralateral breast cancer risk, and then ovarian cancer risk. Again, in the lifetime risk is 13.7. So I had also reached out to our CAN risk expert, Dr. Mark Tishkowitz, about these risks, and particularly the high contralateral breast cancer risk, which I'm not used to seeing being that high. And, some of the feedback he gave me is, this program takes into account the young diagnosis of the first primary. Density doesn't make much of a difference, because I think this woman did have dense breasts. And he just provided a note of caution that contralateral breast cancer risks are not super precise and don't take systemic therapy into account. So they're really to be used as a rough guide. And then ovarian cancer risk, patient did take oral contraceptives, which may explain those risks. So in terms of treatment, here's the treatment regimen: neoadjuvant THP, 4 cycles, and then DDAC, 4 cycles, surgery, possible radiation, possible olaparib. And in terms of family planning, the patient is not finished completing her family, so she did have IVF with 4 eggs harvested. So I just wanted to get Dr. Rajagopal's feedback on this. Sheila Rajagopal is our guest expert. I'm thrilled to have her present at ICARE. She is an assistant clinical investigator at NCI. She's got really neat expertise in bioinformatics, breast medical oncology, and hereditary cancer syndrome, which, again, I think as a group, we all know are super interesting, especially in our field in particular. So her research interests are characterizing genomic and transcriptomic interactions between germline variants, inherited cancer syndromes, and somatic development in tumors to improve clinical prediction and prognostication in patients with cancer. She's received multiple awards. She is very well versed in inherited cancer predisposition, and when she was at the University of Chicago, actually ran the follow-up clinic there focused on inherited cancers. So and as a medical oncologist, I'd love to get Sheila's feedback on the prior case, and then Sheila will get into her talk.
Hi, everyone. Thanks so much. Thank you so much for the very kind introduction to this case is interesting in that technically current NCCN guidelines really focus on olaparib primarily for hormone receptor positive and patients with triple negative disease, and mostly because the frequency of patients who have BRCA associated breast cancer, typically they are not HER2 positive, although you see it. It's not unheard of, but just not as common. So there isn't really a great pathway one way or the other about recommending olaparib in this setting. It is a bit of a dealer's choice. And I think where one might sort of be trying to make a clinical judgment one way or the other would be if, for example, if patients weren't really responding to the HER2 therapy that they were getting, that would help push people more towards sort of anything that they could do to try to help get as much of a response prior to surgery. That would be like one suggestion. Or if they were having contraindications, for example, to different therapies so that they weren't able to get everything that they were recommended for in the neoadjuvant setting. But I think it's a tough call. It's a clinical call. And I think that's sort of very much an active problem in the field in a good way, in that we have more treatment options for patients. That's never bad, but how to organize these in a way that we are benefiting our patients and not sort of subjecting folks to a lot of different side effects unnecessarily, I think is a prime question all around.
Yeah, and I guess this also, as you go through your study, this is one of the reasons, what you are studying could actually really be helpful in guiding treatment, because you're right. Usually we don't see this breast cancer phenotype in a BRCA2 carrier, right? Which was in and of itself a little bit different from what we're used to. So I don't know what to make of it.
But that would be that would be how I'd try to make the decision. But I would sort of say it's discuss with our patients, discuss with our colleagues, and you'd probably get a few different responses back.
Okay, so why don't we get started with your talk, Sheila?
Sure. Now, let's see, this should be going. Yep. Okay. So I'm thrilled to give you all that are on the call today just a little bit of a work in progress project that I'm working on here at the NCI. And what I'm discussing is an algorithm that we're in the process of writing, advancing, and developing to help prioritize competing treatment options for carriers of BRCA1 and 2 mutations who've developed breast cancer. So very relevant to the case we just talked about. And so just for those who may be less familiar with one aspect or the other, I just wanted to cover some brief reminders of where we are in terms of germline testing from the oncologic perspective and from tumor testing in the oncologic perspective. So in terms of state of the clinic, in general, what we find across multiple papers is that when we look at patients who've developed metastatic cancers, about 10 to 15% across cancer types have been found to have pathogenic variants on germline testing. So since 2014, NCCN guidelines have increasingly recommended germline testing in now up to 7 cancer types. That's actively changing, breast being one of them, of course. And so if there's more indications for germline testing, and certainly even within breast cancer, those indications are evolving rapidly, there's generally more context for germline sequencing. And concurrently, sort of from a somatic testing, tumor testing perspective, we're trying to figure out what the tumor actually tells us about what's going on with the cancer and how that helps with finding treatments and how well we anticipate patients will do. There's an ASCO 2020 provisional opinion that recommended that we repeat tumor testing, somatic testing in patients who've developed metastatic disease, particularly in contexts where we think it may be potentially the case that they can be eligible for specific treatments. So it's the case that it is very possible for people to undergo multiple biopsies and multiple sequencing episodes of tumors when they have metastatic disease, where easily 10 years ago that wouldn't have been the case. And this slide I think is already outdated, but there have been multiple FDA-approved treatment-associated biomarkers across cancer types, with multiple that are now considered to be agnostic, where it doesn't really matter per the FDA's approval what the original cancer type was. So if there are more biomarker-associated treatments, we're also doing more tumor sequencing. And I don't want to go through these slides in detail. I just want to highlight exactly what this case pointed out, that when we look at endocrine-driven breast cancers and when we look at triple-negative breast cancers, even in the early stage setting or the metastatic setting, what we find is that there are basically competing options where guidelines try to do their best to navigate the thread of what to pick first or how best to pick between these options. But we don't really have great clinical data about how to organize these for patients who may qualify for multiple therapies. So this is true in the triple negative breast cancer setting between immunotherapy, existing chemotherapy, and olaparib. And it's true in the hormone receptor positive setting between olaparib and abemaciclib in addition to endocrine therapy. And then from the triple negative breast cancer perspective, in the metastatic setting, there are sort of multiple options between immunotherapy with chemotherapy, and some of the new antibody drug conjugates. There are a few different options that compete in order with olaparib and talazoparib, both PARP inhibitors. In general, PARP inhibitors have moved to sort of the first line of treatment, but how to navigate the order of how to give these remains an ongoing question. And the same is true in hormone receptor positive disease that's become what we call refractory, where particularly it's the case that after patients have sort of been on multiple endocrine-driven therapies, have moved on to CDK4/6 inhibitor therapies, and then from there are starting to evaluate what other options they may be eligible for, figuring out which treatments to assign them to is, and sort of that order is an ongoing question. And there have been now increasing studies and more evidence added to this that just sort of putting everything on patients isn't necessarily the most helpful. This is a study from 2020, but it's been supplemented with other work in the literature. This is the Mediola study that was looking at breast cancer, both triple negative and hormone receptor positive, where they gave patients olaparib, PARP inhibitor, and immunotherapy. And what this graph is showing is that there were a series of patients who did respond to this combination and a series of patients who did not respond to this combination. And it really wasn't quite clear how best to choose which patients would or would not respond to that combination of drugs. And really the sort of bulk of people who were responding or seemed to at least be stable were patients with hormone receptor positive disease who would be generally predicted to be sort of doing better compared to the triple negative patients. So all this to say, it's a bit hard to tell what to do with that information. We need to have something more refined to help choose. And then in terms of other information that may be able to help us, I'm going to switch background a couple times a little bit to talk about our project. It's increasingly the case that RNA may be helpful in addition to DNA to help us identify ways to get at more information about tumors that can be relevant for treatment. So this is a study from the Pan-Cancer Analysis of Whole Genomes that was published about 3 years ago now. And that was a landmark series of papers. And in this study, they're looking at 74 different genes that are associated with driving cancers and really pushing cancers to develop. And the yellow is mutations that were identified in DNA in tumors, and the green is mutations that were identified in RNA. And basically what they're showing with this figure is that a proportion of the genes, the 74 genes that they were looking at, they were able to see more mutations in the DNA space. So that they point out a gene, for example, like TP53, which for any oncologists on the call or people who have read sort of sequencing reports, that's very, very common and very familiar as something that shows up as a mutated gene in tumors all the time. But many genes sort of weren't really being seen as being mutated in the DNA space, but having alterations that were relevant in the RNA space. Of course, there were some subset that also didn't have alterations in either one, and some tumors that didn't have alterations that were obvious in either DNA or RNA, so incomplete, but potentially complementary. And I also want to highlight that we are using gene expression data anyway in the context of breast cancer in the US, but primarily for the very specific question of people who have developed early stage breast cancer that is hormone receptor positive, and the specific question that's being asked is whether or not these patients would benefit from chemotherapy. So their gene expression data and all of these different assays that are listed on the left are all different types of assays that look at gene expression. And they offer some degree of prediction of response to chemotherapy and prognostication information. So this is not necessarily unusual ground or totally out of left field. We use it in a clinical context, but the proposition of how to expand that context has been one that sort of hasn't gotten out of this question so far. And then last sort of pivot in terms of other background to help with, for those who may not be familiar, I just want to bring up this concept of synthetic lethality. And this is sort of what is at the root of PARP inhibitor use. I'm giving a very simplified example, but the idea here is that when we're thinking about DNA damage and how a cancer cell sustains itself, the mutations that occur in BRCA1 or BRCA2 allow there to be sort of a break in the system of DNA damage repair. That means that we can induce more and more mutations, which is very relevant if what you're trying to do is break the normal mechanism of how cells divide and just induce consistent replication. The PARP sort of relevant pathway helps with keeping the cell sort of repaired enough to duplicate without necessarily sort of becoming so mutated and so damaged that it can't survive. But if we blockade both of these pathways, what we find between sort of this gene A and gene B, or these two sort of related pathways, is that when we blockade both of them, for whatever reason, BRCA, we know, inherited variants, and PARP inhibitors based on the drug, that process is no longer able to be sustained and a cancer cell dies. So this is the idea of synthetic lethality. You have a gene A and gene B, or systems A and B, that have to work together to maintain cell viability. And if both are gone, a cancer cell can't live. And so the idea of the project that we're working on at the moment, again, a work in progress, so I'm just showing sort of the basic overview of it, is that we can use gene expression data across subtypes of breast cancer to try to stratify subgroups that are more likely to respond to different competing treatment options among people who've developed germline BRCA1 or 2 associated breast cancers using the concept of synthetic lethality. Okay, so tying it all together, what are we talking about? So the aim of this project is to try to use sort of gene expression information and synthetic lethality to try to reference what may be sort of an underexpressed gene and see if we can identify a partner gene that can be targeted with treatment, very generally speaking. And so the way that we're doing that is using existing clinical data to validate and build an algorithm based on an existing published algorithm, and then apply that to patients who have developed germline BRCA1 or 2 associated breast cancers. So just to briefly summarize what this algorithm is, this was developed in the lab of Eitan Rupin, one of the branch chiefs in the Cancer Data Science Group at the intramurally at the National Cancer Institute. And the way that the algorithm works is there's sort of a library in progress. That's the top part in blue. And this library brings together these gene A's and gene B's that both need to be present or only one removed. If both are removed, you have synthetic lethality and the cancer cell can't live. There's many, many ways to assess how there's a gene A and a gene B that are related to each other, and all of these are taken into account in that first filter. Then there's a reference that we can use, a reference of what is normal for breast cancers, to then try to identify, when we look at a given sample, what is an underexpressed gene A, and then associated potential partners based on this list that we've developed. And then the output of the algorithm is a predicted treatment response score, how likely we think that if you blockade that gene B with a treatment, you'll actually see a response. And that really depends on how low your given gene A is and how much we think we can get an effect from a given drug targeting gene B. So hopefully that makes at least some degree of sense, trying to find these pairs where a drug targets this gene B and gene A is inherently underexpressed in the tumor. But in this published algorithm that was written back in 2021, there were only 3 breast cancer studies that were taken into account that included HER2-directed therapy and endocrine therapy. So really not so helpful for the type of drugs that we're talking about related to immunotherapy, related to PARP inhibitors. And this was just what they had available at the time that they published this. It was like pan-cancer algorithm. So in terms of the methods for what we're doing, we're adding significantly more breast cancer reference data to help build out that first part to figure out what is normal. This helps improve the accuracy of the algorithm. And then fine-tuning how these gene A's and gene B's are picked together. And then applying a lot more clinical trial data to sort of assess how well this model does and how well this algorithm does in terms of predicting response to treatment. We can't really apply it to a given patient population where we're actively trying to sort out that question if the model and algorithm doesn't work. So far we've collected existing published data from over 24 studies, including over 13 treatment types in over 3,000 patients, of whom at least 5 of these 24 trials sorted out BRCA1 and 2 mutation status. And so the relevant part for the ICARE program is that the validation of how well this algorithm works, and particularly in the patient population we're interested in sort of helping support, is that patients with germline BRCA1 and 2 associated breast cancers, that treatment information is hugely helpful to validate whether or not our algorithm is actually able to predict who did respond to treatment and who didn't. So for those who are participating in ICARE or referring patients to ICARE, it is hugely helpful to have this treatment response data so that we can validate that this algorithm works for the patients that we're trying to help. And so this is, as I said, just a work in progress summary. The goal of this project and this algorithm is to try to use gene expression data and synthetic lethality to help figure out who may be appropriate candidates or better candidates for existing approved therapies in germline BRCA1 and 2 associated breast cancers. And we're in the process of developing this algorithm now. The goal is that we should be able to pick among these clinical treatments that a given patient population may be, or a given patient group within the population of BRCA1 and 2 associated breast cancer may be more likely to respond to immunotherapy or maybe more likely to respond to PARP inhibitors. That's what we're trying to sort out. And the hope is that future research would be able to we're able to validate this algorithm works and we're able to validate it in this population, we'd be able to apply it sort of more directly in the clinic. So thank you all so much.
Thank you, Sheila, for an excellent presentation.